It was the third Tuesday in September when Eleanor took the cold medicine that gave her a stroke. She was 71, a retired second-grade teacher. She lived in a yellow house on the corner of Elm Street in a small town in Pennsylvania. In the same house, she and her husband had moved into the year their first daughter was born. She had been fighting a stubborn fall cold for almost a week. The kind that settles into your sinuses and makes everything sound like you are speaking from inside a barrel. The kind that wakes you at 3 in the morning because you cannot breathe through your nose. The kind that turns your voice into a stranger's voice on the phone and makes your grandchildren ask if you are sick. On Tuesday afternoon, after 5 nights of broken sleep, she walked into the pharmacy 2 blocks from her house and bought 2 things she had bought 100 times in her life. A box of name-brand daytime cold medicine and a bottle of nighttime pain reliever with a sleep aid built in. The same 2 products she had taken in her 40s when her children had brought home colds from school. The same 2 products she had taken in her 50s when she was still teaching. The same 2 products that, at 71, on top of the 3 prescription medications she was already taking for her blood pressure and her cholesterol, sent her to the emergency room the next morning, with the left side of her face drooping and her right hand unable to grip the railing of her own stairs. There are 5 pills sitting in the medicine cabinets of millions of older adults in this country right now that the published cardiovascular research suggests may be raising the risk of heart attack and stroke more than almost anyone is talking about. I'm going to walk through all 5 today. I am going to tell you exactly what the evidence does and does not say about each one. And by the end of this video, I am going to name the one of the 5 that I see causing the most quiet harm in my own practice, in the homes of patients who never thought twice about it. I am Dr. Samuel Hart. I have spent more than 2 decades in internal medicine with a focus on cardiovascular care, and I want to be honest with you before we go any further. I am not here to scare you off your medication. I'm not here to tell you your doctor is wrong. The medications we are going to discuss are not banned, are not secretly poisonous, and are not part of any conspiracy. Most of them are useful tools when used appropriately. The problem is not the pill. The problem is that the dose your body could safely process at 50 is not the dose your body can safely process at 75. And almost nobody in the pharmacy aisle has been told that. And almost nobody in a 15-minute office visit has the time to explain it. What happened to Eleanor was not a freak accident. It is happening right now, in pharmacies and kitchen cabinets across this country every single day. Stay with me, because the 5 pills we are going to cover today are sitting on more shelves than you would believe possible, and the changes you can make tonight are simple, safe, and free.
Let me come back to Eleanor's evening, because the rest of the story is in the details. She got home from the pharmacy at 4:30.
She unpacked her grocery bag at the kitchen counter, set the 2 boxes on the windowsill next to her potted basil, and made herself a cup of chamomile tea. She took the daytime cold medicine with a glass of water before dinner, just as the box instructed. The active ingredient was a common decongestant that has been on American shelves for decades. After dinner, around 8 in the evening, her chest felt tight, but she told herself it was the cough. She watched the news with her husband. She did the dishes. She wiped down the counter and folded the dish towel over the oven handle, in the same exact motion she had done every night for 51 years of marriage. At 9:15, she took 2 tablets of the nighttime sleep formula, exactly as the box instructed, because she was tired and wanted to actually rest for the first time in 5 nights. The active ingredients were acetaminophen and diphenhydramine. She fell asleep around 10. At 5:47 in the morning, she woke up and tried to swing her legs out of bed and could not feel her right foot. Her speech was slurred when she called for her husband. Her right hand could not push back the covers. The ambulance arrived 9 minutes later. The paramedics ran through their stroke protocol on the ride to the hospital. Time of last known wellness, 10 the night before. Symptoms confirmed at 5:47. Window for intervention closing. The CT scan in the emergency room confirmed an ischemic stroke. She was in the hospital for 6 days, then in a rehabilitation facility for another 12. The neurologist who managed her care during recovery asked her one question that nobody had thought to ask her at the pharmacy. "What did you take yesterday?" She listed her prescription medications. He nodded. He had those already. He asked again, "Anything from a drugstore? Anything for the cold? Anything to sleep?" she told him. He sat down on the side of her bed. What Eleanor did not know, and what the box on the pharmacy shelf will not tell you in plain language, is that the combination of products she took in a single evening included 3 of the 5 medications I'm about to walk through. 3, not 5. 3. and the combination, layered on top of the prescriptions her body was already managing, was enough to set off a chain reaction in her circulatory system that her cardiologist had spent 10 years working to prevent. Let me walk through them. The first pill, common over-the-counter pain relievers known as NSAIDs. I'm talking about ibuprofen, sold under names like Advil and Motrin. Naproxen, sold as Aleve. Diclofenac, sold as Voltaren. These are the over-the-counter pain medications that millions of older adults take like candy, often several times a week for arthritis pain, headaches, back pain, knee pain, or any minor discomfort. They are sold without a prescription, which most people assume means they are safe. They are recommended by friends. They are bought in bulk at warehouse stores. They sit in purses, in glove compartments, in kitchen drawers, in nightstand drawers, in every room where someone might reach for one without thinking. Here is what the published research actually shows. In 2015, the United States Food and Drug Administration strengthened the warning label on all non-aspirin NSAIDs to reflect a confirmed elevation in the risk of heart attack and stroke, even with short-term use. The warning specifically applies to people who already have cardiovascular disease, but the data also shows elevated risk in people without prior heart disease who take these medications regularly. The American Heart Association has been clear about this for years. Older adults with high blood pressure, heart failure, or kidney disease should approach these medications with significant caution. The mechanism is straightforward, and I want to walk you through it carefully, because understanding it makes everything else in this video easier to follow. NSAIDs block enzymes called cyclooxygenase, which the body uses to produce a family of signaling molecules called prostaglandins. Some prostaglandins drive the inflammation and pain that you want to suppress. That is why NSAIDs work for a sore knee or a headache. But other prostaglandins do a different job. They protect the lining of your arteries. They help your kidneys regulate sodium and fluid balance. They keep blood vessels appropriately relaxed. When you suppress the bad prostaglandins, you also suppress the good ones because the drug cannot tell them apart. The result, especially in an older body where the kidneys are already working at reduced capacity, is that blood pressure rises. Fluid retention worsens. The strain on the heart goes up. In someone already on blood pressure medication, the NSAID can quietly cancel out the effect of the very prescription that is keeping them safe. The blood pressure numbers at the next office visit look slightly worse. The cardiologist increases the dose of the blood pressure medication. The patient takes more medication, which has its own side effects, and nobody connects the cascade to the ibuprofen the patient has been taking 3 times a day for their knees. Eleanor was not on regular NSAIDs. She had not been one of those patients. But layered into the broader picture, NSAIDs are, in my own clinical experience, the single most common medication contributing to silent cardiovascular deterioration in adults over 60. I want you to remember that because we are going to come back to it at the end of this video. Here is what to do. Talk to your pharmacist before reaching for ibuprofen or naproxen for chronic pain. For occasional short-term use, acetaminophen, sold as Tylenol, is generally safer for the cardiovascular system in older adults, though it has its own considerations with the liver and at high doses. For chronic pain, your doctor can help you build a plan that does not rely on daily NSAIDs. Physical therapy, topical formulations like diclofenac gel that act mostly on the joint and have less systemic absorption. Targeted exercise, heat, cold, acupuncture, acetaminophen at appropriate doses. The plan does not have to look the same as it did in your 40s. The second pill, decongestants. This is the one Eleanor took on Tuesday afternoon. I am talking about pseudoephedrine, sold under names like Sudafed and phenylephrine, which is found in many multi-symptom cold and flu products. These are the active ingredients that shrink swollen blood vessels in your sinuses to relieve congestion. They do not, unfortunately, only act on your sinuses. They constrict blood vessels throughout your entire body. Here is what the published guidance says. The American College of Cardiology and the American Heart Association have both issued formal statements that decongestants containing pseudoephedrine or phenylephrine can raise blood pressure and heart rate, and should be used with caution or avoided entirely in patients with uncontrolled hypertension, coronary artery disease, or a history of stroke. The mechanism is simple. When you constrict the blood vessels throughout the body, the heart has to push harder against the resistance. Blood pressure climbs. Heart rate often climbs with it. The body responds the way it responds to any sudden vascular stress. In a younger, more flexible cardiovascular system, the change is minor. In an older system with stiffer arteries and pre-existing high blood pressure, the change can be significant. There is a second layer that almost nobody thinks about. The vasoconstriction does not stop when the cold symptoms resolve. The drug continues to circulate for hours after the dose, especially in older adults whose livers metabolize medications more slowly than they did at 40. A single dose for a single bad cold day is unlikely to cause a stroke in a healthy older adult. But layered on top of 3 days of cold symptoms, 3 nights of poor sleep, 3 prescription medications already working hard to keep blood pressure controlled, and the second over-the-counter product Eleanor took at bedtime, the additional spike from a decongestant can be the tipping point. That is what tipped Eleanor. And the second over-the-counter product Eleanor took at bedtime, the additional spike from a decongestant, can be the tipping point. That is what tipped Eleanor. Here is what to do. Before you buy any cold or flu product, read the active ingredients. If you see pseudoephedrine or phenylephrine, talk to your pharmacist about whether it is appropriate for you given your blood pressure status and your other medications. There are alternatives that do not affect the cardiovascular system. Saline nasal sprays, which physically rinse mucus from the sinuses without any drug effect. Steam from a hot shower or a bowl of hot water. Antihistamines that do not contain a decongestant can help. Nasal strips for breathing at night. Honey and warm tea for the throat. A humidifier in the bedroom. None of those will spike your blood pressure. Let me tell you about another patient briefly, because Eleanor's story is not the only version of this story, and the variety matters. I will call him Walter. Walter was 76, a retired insurance adjuster. He woke up one March morning with a sinus infection that had been building for 3 days. He drove to the pharmacy. He picked up a multi-symptom cold and sinus product that contained pseudoephedrine, an antihistamine, and acetaminophen, all in one tablet. He read the box. He took 2 tablets at breakfast as directed. By lunchtime, he had a pounding headache he assumed was from the sinus infection. By mid-afternoon, he was nauseated. By the time his wife came home from her book club at 5:30, he was disoriented and could not finish a sentence. She called 911. His blood pressure on arrival was severely elevated, in the range cardiologists call a hypertensive emergency. He had not had a stroke. He had what cardiologists call a hypertensive crisis. The vasoconstriction from the decongestant, layered on top of a body already managing one prescription antihypertensive, had pushed his pressure past the level his system could tolerate. He recovered fully. The combination of medications was the only thing that changed that day. Walter and Eleanor do not know each other. They never will. But the boxes on the pharmacy shelf that almost ended both of their lives are stocked right now in every drugstore in this country, and millions of older adults pick them up every season without a second thought. Protect your heart and always read the label. The third pill. Over-the-counter sleep aids and PM-formulation pain relievers. This is the second pill Eleanor took on the night of her stroke. I am talking about diphenhydramine, sold under the name Benadryl, and the same ingredient found inside Tylenol PM, Advil PM, ZzzQuil, and many generic store-brand sleep aids. Most people do not realize that the PM in those product names is exactly the same drug as Benadryl, the allergy medication. It is added because it makes you drowsy. Here is what the research and the major geriatric medicine guidelines say. The American Geriatric Society maintains a list called the Beers Criteria. The Beers Criteria is a regularly updated guide to medications that are potentially inappropriate in older adults. Diphenhydramine is on that list. The reason is that diphenhydramine belongs to a class of drugs called anticholinergics, which interfere with one of the body's key signaling chemicals, acetylcholine. In older adults, this interference can cause confusion, urinary retention, falls, and increased heart rate. There is also a growing body of research linking long-term anticholinergic use to increased rates of cognitive decline and cardiovascular events in older adults. The most concerning issue for the heart is the effect on rate and rhythm. Diphenhydramine can affect heart rate and at higher doses contribute to rhythm changes in some patients. In a body already managing high blood pressure, the cumulative effect of a nightly PM pill, especially layered with a daytime decongestant, can be more than the system can absorb. There is one more layer of risk that almost nobody discusses. Diphenhydramine is what doctors call a strongly sedating antihistamine. It can cause prolonged grogginess the next morning. That grogginess is when falls happen. A patient gets up at 3 in the morning to use the bathroom. They are half asleep, blood pressure shifting with the change in position, head still cloudy from a medication that is still half active in their bloodstream. They catch their foot on the edge of the rug. The fall happens, the hip fractures, the cascade begins. Many of the falls I see are quietly related to a PM pill. Here is what to do. If you are over 65 and using diphenhydramine-containing sleep aids regularly, please talk to your doctor about alternatives. The first interventions are not pharmacological at all. Cool, dark bedroom, consistent bedtime, limit caffeine after lunch. Reduce evening fluids. Address nighttime bathroom trips. Consider whether your current medications are timed in a way that affects your sleep. Check if your blood pressure pills or diuretics are timed in a way that affects your sleep. For occasional pain, plain acetaminophen is generally a safer option. Plain acetaminophen without the PM addition is generally a safer option in older adults. If sleep is a chronic problem, talk to your doctor about it directly. There are non-anticholinergic approaches that have a far better long-term safety profile. I want to pause here for one moment. We are about to cover the last 2 pills on this list, and these are the 2 that often surprise people the most. If anything we have discussed so far has applied to you or to someone you love, type the word 1 in the comments below. I read every one of them. The patterns in those answers tell me which medications to make the next videos about. Now let's keep going. The 4th pill, long-term oral corticosteroids. I am talking about prednisone, methylprednisolone, dexamethasone, and similar drugs taken in tablet or liquid form for extended periods. Steroids in this form are prescribed by doctors for a wide range of conditions, including severe arthritis, autoimmune diseases, and lung conditions like COPD, certain skin problems, and post-transplant care. They work often dramatically, which is why they get prescribed, and why patients sometimes find themselves on them for months or years. Here is what the cardiovascular research consistently shows. Long-term use of oral corticosteroids is associated with measurable increases in blood pressure, blood sugar, body weight, and fluid retention, and the risk of heart failure, heart attack, and stroke. The American Heart Association and multiple cardiology guidelines explicitly call out chronic corticosteroid use as a modifiable cardiovascular risk factor. The mechanism involves changes in how the body handles sodium, fluid, and glucose, along with effects on blood vessel function and inflammation pathways. Let me make this more concrete because abstract risk percentages do not land the way they should. When you take an oral steroid for weeks at a time, your body retains more sodium and water. The retained fluid increases the volume of blood your heart has to pump with every beat. The blood pressure climbs. At the same time, the steroid drives blood sugar higher, which over months and years contributes to insulin resistance and full diabetes in patients who never had it before. The combination of higher blood pressure, higher blood sugar, and weight gain is essentially the recipe for accelerated atherosclerosis. The arteries stiffen, the plaques grow. The risk of heart attack and stroke climbs measurably year over year. This does not mean steroids should never be used. For many patients, they are genuinely life-changing or life-saving. A patient with severe rheumatoid arthritis whose joints are being destroyed may need years of steroid therapy to preserve her mobility. A patient with a severe asthma exacerbation needs a steroid burst to keep breathing. A patient with an autoimmune flare may need long-term immune suppression that no other medication can provide. The conversation is never as simple as stop the steroid. The conversation is always about whether the dose can be lowered, whether the duration can be shortened, or whether other medications can spare some of the burden, and whether the cardiovascular monitoring that should accompany steroid use is actually happening. Here is what to do. If you are on an oral steroid for more than a few weeks, ask your prescribing doctor 3 specific questions. What is the lowest dose that controls my condition? What is the plan to eventually reduce or stop this medication? And how are we monitoring my blood pressure, blood sugar, and cardiovascular risk while I am on it? Those 3 questions, asked clearly, signal to your physician that you want to be an active partner in managing the trade-off. The 5th pill, triptans and certain migraine medications. This is the one almost nobody discusses, but I see it frequently in older adults who started taking these medications in their 40s or 50s for migraines and continued taking them as their cardiovascular risk profile changed over the decades. I am talking about sumatriptan, sold as Imitrex along with rizatriptan, zolmitriptan, elatriptan, and similar drugs in the same class. They are highly effective at stopping migraine attacks because they constrict blood vessels in the brain. The mechanism is exactly what makes them effective and exactly what makes them risky as the patient ages. Here is what the prescribing guidance has said for years. Triptans carry specific warnings about use in patients with known coronary artery disease, prior heart attack, prior stroke, uncontrolled high blood pressure, and certain heart rhythm disorders. The problem I see most often in practice is the patient who was prescribed a triptan at 52 for migraines and is still taking it occasionally at 74 without ever having had the conversation about whether their now elevated cardiovascular risk has changed the risk-benefit calculation. Ask whether the current evidence still supports your continued use given your current cardiovascular status. There may be safer options for migraine management. Newer medications called gepants may be appropriate alternatives. The conversation does not have to end in a change, but it does need to happen. Take the medication name to your next appointment. Let me come back to Eleanor. 6 weeks after her stroke, she was back home in the yellow house on Elm Street. Her speech was clear again. Her right hand had recovered most of its grip. She was using a small notebook to track her words because some of them, especially names, still slipped away from her in the late afternoon. The neurologist had explained that this kind of mild residual deficit was common after a stroke of her size, and that with consistent therapy, much of it would continue to improve over the following 6 to 12 months. Her physical therapist came twice a week. She walked the 4-block loop around her block 3 times every morning. She was lucky in the way that some stroke patients are lucky because the part of her brain that was affected was small and recovered well. She had also been unlucky in the way that millions of older adults are quietly unlucky every year. She had taken 3 over-the-counter products on a single evening, completely within the dosing instructions on every box, completely within the bounds of what she had safely done 100 times in her younger life. And the cumulative cardiovascular effect on her 71-year-old body had been enough to trigger an event she had spent a decade trying to prevent. She asked me a question one afternoon during a follow-up appointment that I think about often. "Doctor, if those boxes are dangerous for someone like me, why are they on the shelf?" The honest answer is that the boxes are not dangerous for everyone. They are useful, effective products for the right person at the right time at the right dose with the right context. The pharmacist does not have time to evaluate every customer who walks in with a cold. The box does not know about the 3 other prescriptions in your medicine cabinet. The labeling system was built for a population that includes everyone from a 24-year-old with a head cold to a 74-year-old on 3 antihypertensives. And the warnings on the back of the box have to cover all of them with a few small lines of fine print that almost nobody reads. The honest answer is also that the pharmacy does not have time. The honest answer is that the boxes do not say it in plain enough language. The honest answer is that a 15-minute office visit cannot cover every product on every shelf. The system is not malicious. The system is simply too rushed to give each older adult the careful conversation they deserve about how the body they have at 70 is different from the body they had at 50. So let me give you the conversation. Here is what to do this week. Walk into your bathroom. Open the cabinet where you keep your medications and your over-the-counter products. Take out every box and bottle that contains the words PM, cold, flu, sinus, cough, pain reliever, or sleep aid. Read the active ingredients on the back. If you see ibuprofen, naproxen, diphenhydramine, pseudoephedrine, or phenylephrine, take a picture with your phone. Bring those pictures to your next appointment and ask your doctor or pharmacist a single question. Given my age, my blood pressure, my heart medications, and my history, are these still safe choices for me? That conversation, 10 minutes long, can be the most important conversation you will have in a doctor's office this year. There are a few specific scenarios I want to prepare you for because they come up over and over in real life. And they are the moments when the over-the-counter aisle becomes the most dangerous. The first is cold and flu season. Between October and March, almost every adult will catch at least one cold. The instinctive move is to walk into a pharmacy, pick up the products on the front display, and self-treat. Before you do that, pause. Read the active ingredients on the front of the box. Avoid combination products that have multiple active ingredients you do not specifically need. If your only symptom is congestion, you do not need a multi-symptom product. If your only symptom is a cough, you do not need a decongestant. The fewer active ingredients you take, the fewer cardiovascular interactions you are layering into a body already managing other medications. The second is unexpected pain, a fall in the garden. a pulled muscle from helping a grandchild up off the floor, a bad night's sleep on a strange pillow. Before you reach for ibuprofen or naproxen out of habit, consider whether plain acetaminophen would work for the situation. For most short-term pain in older adults, it does. If the pain is severe enough that acetaminophen is not enough, that is a conversation for your doctor, not a reason to default to an NSAID. The third is trouble sleeping. After 60, sleep patterns change. Most older adults are not sleeping the way they did at 40. Before you reach for a nightly PM formulation product, look at the basics first. Caffeine after noon, alcohol in the evening, screens before bed, a warm bedroom, an overactive bladder waking you at 2 in the morning, pain that you are managing with the wrong medication at the wrong time. All of these have non-pharmacological solutions that do not involve adding an anticholinergic to your nervous system every single night. The fourth is post-surgical recovery. After a procedure, you will be given pain medication and recovery instructions. Bring your full medication list, including the over-the-counter products you take regularly, to your pre-surgical appointment. Many cardiovascular complications after surgery in older adults are related to medication interactions that nobody flagged because nobody knew about all the products being taken. And here is what I do not want you to do. I do not want you to stop any medication on your own based on this video. I do not want you to throw out your prescriptions. I do not want you to call your doctor's office and demand changes without context. Your prescription aspirin, your statin, your blood pressure medication, and the other prescriptions your physician has built into your care plan are different conversations entirely, and they are working to protect you. Do not stop them based on this video. Bring questions about them to your doctor. What I want you to do is bring the conversation into the room, ask the questions. Make sure that the plan that was right for you 10 years ago is still the plan that is right for you today. Bodies change, risk profiles change. Medication choices should change with them. I told you near the start of this video that I was going to name the one of the 5 pills I see causing the most quiet harm in my own practice. Here it is. It is the first one we discussed. NSAIDs, ibuprofen, and naproxen. Not because the cardiovascular risk of any single dose is the highest, it is not. It is because of the volume, because of the daily for years use, because of how routine it has become to take an ibuprofen for everything, and how rarely the conversation about cumulative cardiovascular risk happens. Decongestants, PM sleep aids, long-term steroids, and triptans all matter. But if I could change one habit in the homes of every adult over 60 in this country, it would be the casual, automatic daily reach for ibuprofen. That one change would prevent more strokes and heart attacks than any other behavior I can think of. Eleanor is doing well now. 8 months after her stroke, she is back to teaching her Sunday school class. She does the New York Times crossword in pen again, though she allows herself to use the puzzle's checking feature when a name escapes her, something she would have considered cheating before. Her granddaughter visits on Sundays for lunch, and Eleanor makes her famous chicken and dumplings. Because muscle memory in the kitchen came back faster than almost any other skill. She keeps a small notebook in her purse now with a list of every medication and every over-the-counter product she is currently taking. And she brings it to every appointment. She showed me the notebook the last time I saw her. The first page is blank except for a single sentence she wrote at the top in pen. Ask before you swallow. That sentence is the entire lesson of this video. Walter went back to his book club and his daily walks. His cardiologist tightened his blood pressure plan with a slightly different regimen. And he learned to ask the pharmacist a single question before buying anything in the cold and flu aisle. Is this safe with my blood pressure medication? He says he gets a clear answer every time, and the answer has changed his buying habits permanently. 2 patients, 2 quiet near misses, 2 lives that look different now because someone asked the right question at the right time. If you take any medication regularly, prescription or over-the-counter, I want you to do one thing this weekend. Make the list. Write down every pill, every capsule, every gummy, every supplement, every spray, every patch, every cream you put on your skin that contains an active medication. Write down the doses. Write down how long you have been taking each one. Bring the list to your next appointment and hand it to your doctor with the 6 words I have been teaching my patients to use. Can we go through these together? Most physicians have never been asked that question by a patient. Most physicians will sit down with you and go through the list one by one. Some of them will be glad you asked. Some of them will discover things they did not know you were taking. Some of them will be the ones who finally catch the interaction that has been quietly building for years. If this video helped you think about your medicine cabinet differently, please share it with someone you love who manages their own pills. especially the over-the-counter ones, without much oversight. There's a very good chance they will recognize at least one of the 5 products we discussed today. Your share may be the most useful thing you do for their health this entire year. Subscribe to the channel so you do not miss what is coming next. In the next video, I am going to walk you through the 5 conversations every adult over 60 should have with their pharmacist. Because the pharmacist is often the most underused safety check in your entire medical care, and the conversation costs nothing. Everything I shared today is general medical information based on published research and clinical guidelines, and it is not personal medical advice. Please talk to your own physician or pharmacist before changing any medication. I am Dr. Samuel Hart. Ask before you swallow. I will see you in the next video.